Novelist and humorist Mark Twain once observed, "If we were meant to talk more than listen, we'd have two mouths and one ear." True in his lifetime and just as true today. In order for the American Hospital Association to be the most effective voice it can be for members, it needs to listen to their concerns. That means personal visits and face-to-face conversations with the leaders of hospitals and health systems across America, hearing firsthand how they are addressing the challenges and opportunities in our rapidly changing field. It's incredibly important work, and a big part of the job for Dr. Chris DeRienzo, the AHA's Chief Physician Executive. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle with AHA Communications. As a neonatologist who has cared for some of the tiniest patients in a hospital, Dr. Chris DeRienzo learned early on there is no substitute for spending time with the patient firsthand. In 16 months with the AHA, he's traveled to 27 states and racked up 400,000 sky miles, putting that principle into action. In this podcast, Dr. DeRienzo shares with the AHA's Elisa Arispacochaga, Vice President for Clinical Affairs and Workforce, what he has heard and learned from spending a significant amount of time visiting with members. One key takeaway, it's clear there will never be a one-size-fits-all solution that works for everyone to solve the challenges we face in healthcare. Let's join them.
Thanks, Tom. I'm Elisa Arispacochaga, AHA Vice President of Clinical Affairs and Workforce, and today I'm really excited to talk with AHA's Chief Physician Executive, Chris DeRienzo, who spends a good amount of his time around the country meeting with many of our members and understanding both the challenges and the opportunities that they're presented with. So I'm really excited to hear about his work. So, Chris, I know you came to this from one of our member hospitals. Can you give just the thumbnail sketch of how you got from there to here?
You bet, Elisa, and always a pleasure to get to join our podcast. And this, I'm hoping, will be the first in a series of conversations that we get to have with members and listeners about what, frankly, is the best part of my job, and that is getting to travel this country and to be with our hospitals and the people who work within them. So I'm a neonatologist clinically. I spent the last 10 years working in chief physician roles in health systems in North Carolina. In the western part of the state, in middle of the state, in urban and rural, community, academic, investor-owned and nonprofit. So I really got how to run health systems in North Carolina. But back when I was interviewing for this role, I made sure to be really clear about the fact that that doesn't mean that I understood what it was like to lead in healthcare all over the country. And so that's what led me to the kind of conversation we get to have today. I've been lucky now to be part of the AHA team for about 16 months. And as you know, in those 16 months so far, I've been to 27 states and have earned something like 400,000 frequent flyer miles on American Airlines. And so that's a lot of travel. We get to see a lot of the country. So really excited to get to spend some time with you today talking about the kind of things that we learn while out visiting with our members.
Absolutely. And I agree. It definitely is one of my favorite parts of my job is getting to see both the impact we can have and then how our members are doing so many amazing, innovative things. So you've gone from the very micro environment of care delivery and taking care of some of our tiniest patients to a very macro view of what's the operational policy, the organizational needs, and now a national agenda looking at care delivery, at patient safety. What are the things you carry with you that are key lessons even from those days of taking care of those tiny infants that help you do your work?
Yeah, Elisa, there are many, but I'll just share one for the context of this podcast. One thing that you learn really quickly as a pediatrics resident, and frankly as a neonatologist, is when the nurse at the bedside gives you a call and says, there's something going on, you go and see the patient. And that in part is because the level of experience in those team members who spend every hour at a bedside they really get to know what's going on there. And one thing I learned in clinical practice is there's a lot you can manage by phone. Don't get me wrong, but in order to really get a feel for the situation as your partner is seeing it firsthand, you got to go and see the patient. And sometimes when you go and see the patient, you can be reassuring, and sometimes your level of energy very rapidly escalates. Frankly, the same is true in leadership, and the same is true for understanding what healthcare looks like all over this country. So, as it relates to what we're doing here at AHA, we are incredibly lucky to get to speak for our members in the halls of Congress, with the White House, other members of the administration, and also to a variety of national media outlets. And as I've learned in the time I've spent at the association, in order to do that job really well, it also means we have to spend a significant amount of time visiting with our members. And they're thankfully invite us into their professional homes. We get to go to their hospitals and really see what it is like to live their lives and to serve their communities firsthand.
Absolutely. I completely agree. I think getting to not only hear their stories, but then make them part of what you get to share on a national level is really important. As part of your travels, you're really learning a lot about some of the approaches organizations are taking to address the tsunami of change that's coming towards them, whether it's the changing demographics of their communities, the workforce shortages they may be plagued by, or some of the challenges related to how they support technology. How are you finding leaders staying hopeful? And then what are some of the approaches they're taking to really bring their teams along and help support them as they go through this change?
Yeah, I think one thing that's become incredibly clear to me is that there is never going to be one solution that will work to solve the challenges we face in healthcare all over this country. And I'll give you a couple of examples. We know that today we're experiencing a real challenge when it comes to labor and delivery around the country. We know that there are shifting demographics in America today that's leading to changes in birth rates. We know that our workforce, from a recruitment and retention perspective, is incredibly challenged, especially in labor and delivery. And we know that the financing system is problematic, with nearly 50% of deliveries in this country covered by Medicaid, and Medicaid being a provider that rarely even covers the cost of the services we provide. That has frankly led to a perfect storm of challenges. And when I've gotten to visit different parts of the country, the ways that folks are solving from them look very different. There are some places in, for example, northeastern part of Kansas, where the medical staff consists of 4 full spectrum family medicine physicians. And preserving access to labor and delivery in that community looks wildly different than in, say, other parts of incredibly rural parts of the Dakotas, or in some of the urban core centers where workforce is still a really problematic challenge. But what I see from a hopeful perspective are the innovations that are happening within those local centers, and being able to innovate around what is the right resources to serve our community. In Iowa, for example, I was able to see some of that innovation at work, as there's some grants funded by state government that have allowed for centers of excellence to pop up in certain communities, and that is the kind of spark that educates us at a national level around what are the kind of things that we can help solve for nationally, and where do we need to help lift up stories of what's working within local communities, so that our health systems, who really are embedded in and integrated with the communities they serve, can look to apply those lessons as best as they can within their unique circumstances.
Agree that the ability to share those stories of what different organizations have brought together to make this work. No one is going to pick it up and do it exactly the same, but it's going to inspire a thought, an idea, hey, maybe we could. That I love to see. I love to see where people can take this, because if nothing else, that I've learned in my own travels is that there's no one in healthcare who doesn't pretty much want to be there because they have just a burning desire to help.
Elisa, that's exactly right. And I think that we're challenged by the experiences through which we've lived. I've been fortunate to live in North Carolina in communities large enough to have multiple pediatricians because there are so many children in the counties that I've lived in. But I've gotten to visit counties who, when you combine the populations of 4 counties together, you still don't have enough children just to be able to have one pediatrician there. And I think it's challenging when, at a national level, a lot of the folks who engage in those conversations about what does healthcare look like, they've never seen that environment, much less lived through it. And so it's easier for me as a double board certified pediatrics and neonatologists to have kind of one definition of what I think access looks like. But when you get out into other parts of the country and you get that sense for this community is different, that the nature of access to care here is different. We have to think differently about projecting subspecialty expertise from other centers in order to get it here. It really does reframe the way you think about the conversation.
I still will never forget the day I learned from one of our members in a very rural area that helicopters only fly about 150 miles before they need to refuel.
That's right.
And that's why he used a fixed wing air ambulance to transport patients who needed more care than he could provide. It was a very humbling moment for someone who grew up in the middle of a city. So let's dig into that a little bit, because you've clearly seen organizations where you can have subspecialties, right there at the bedside in minutes, to you're the hospital you just mentioned with a medical staff of 4 people. How do you see some of the field evolving to address this challenge?
Yeah, I think there are a lot of different ways that I've seen hospitals and health systems approach that, in part because in some cases, one of the great values of an integrated delivery system means that you can have sort of centralized subspecialty expertise within your own health system and project it either via telepresence or via physical presence into those communities. So some systems approach this by having rotating specialists, who are spending perhaps most of their time within a tertiary center in a larger community, but then are taking clinics 1 day a week or 2 days a month or 1 day a month, even within a more rural site that may be a couple hours away. Others, like Dartmouth up in New Hampshire, are able to project subspecialty expertise from their academic center into many of their rural partners via telepresence in other parts of the state. We see that with the folks at Sanford Health up in the Dakotas, where through a pop-up telemedicine site, they are able to see pediatric subspecialty patients in a local small office that's in a downtown of maybe 1,000 people, that otherwise would require that family to drive 1,100 miles round trip into Fargo to be able to see that team. And then I got to see this in one critical access hospital, again staffed by family medicine physicians, terrific doctors in the emergency department, but they're not trained in trauma to the level of say a level 1 trauma center is. So they had in their emergency department rooms, there were 2 rooms, and on the walls of each room was a massive television and a partnership by which, at the press of a button, they could bring in the EM boarded physicians who have recent trauma experience for the incredibly rare time that emergency department sees, a very significant trauma patient. And while they can drill on it and they can practice, having that partner, that subspecialty partner, being able to look in and walk through that case with you, that's an enormous benefit. And again, goes back to the kinds of local innovation that we see all across the country within AHA's members. And I know you've seen some examples of this firsthand as well.
Absolutely. The one that comes to mind was at the Children's Hospital in Colorado, where they created a multi-specialty clinic series so that they could bring, for patients who in many cases were driving from 1 or 2 states away, they could come and see all of the clinicians they needed to see for their child's care without having to spend, a week going from appointment to appointment. Everybody was together and it was focused on what that child needed. I just love that they centered it on the child.
And to be able to do that in that children's hospital required a significant amount of resource. And we know that health systems rely on many different sources of funding streams in order to make that happen. And that hospital, I remember that visit vividly because I was envious of that clinic space. They had so many resources that they could pull together in that one space. And you're right, put the patient at the center and be able to serve these kids who really, really needed that subspecialty help.
So as you think about this and now, think through sort of your own training and how you went through and learned how to care for the kids that were in your care, how do you think the training of our future clinicians, and I mean that broadly, not just physicians, needs to start to shift so that they're ready to go not only to an academic center down the street to practice where they can call and have 20 people come consult, to practicing in those locations where they may not have that physical presence, but they may have another way to interact with the subspecialties they need.
I think the training needs to evolve right along with the practice, yeah, as it has for generations. But the kind of evolution that's empowered by technology today is really important. I remember eons ago when I was a NICU fellow, we would fly out to some of the rural places where preemies would be born, and we would join the helicopter team on the flight because sometimes you would need someone who is skilled in intubating a really tiny baby or managing pulmonary hypertension. But the phone calls that we would get, we would be managing via phone. Now, much of that management can happen via telemedicine. And so figuring out how to expose trainees to those kinds of teleconsults, especially within an integrated system. I remember the first time as a neonatologist that I was requested to have teleprivileges was within one integrated health system that had a remote labor and delivery service up in the mountains. And for the first time, we had the technical capability to not just get on the phone with the team who was there in the delivery, but also beam in and be able to get visual on the resuscitation as well. That was a huge leap, and that was almost 10 years ago now. And so today's trainees are growing up in an environment where that's increasingly becoming a kind of part of the expected table stakes is being able to not only manage in person, but support via some kind of telepresence. We're seeing it in the physician world, and absolutely, I know our partners at AONL are seeing that in the nursing world too.
Was really excited to hear about some of the work that Providence in particular had done. And actually, through their virtual nursing, were able to catch a patient who was exhibiting signs of a stroke.
Wow.
That's how good their cameras and their interactions are virtually, to be able to call the bedside team, bring them in, and address that patient's needs immediately. Something that might not have been caught as fast had the virtual nurse not been having a conversation.
It's this kind of innovation, and I know we share this opinion that it's both when you're approaching it from both a patient-centered perspective and from the notion that we know we're in the middle of a workforce crisis, one that we cannot recruit our way out of, and that we must be able to innovate around how to project workforce experience in different ways. That's just such a great example of ways that our members are innovating, and I'd love the chance here to get to lift them up.
Well, Chris, I really enjoyed getting a chance to hear about some of the places that you've been, some of the things you've seen, and I look forward to where your travels take you next.
It's a lot of fun, Elisa, and I say it all the time. I'm frankly the luckiest doctor in America to get to do this work. I cannot count the number of states that I get to visit over the coming months, but I'm really excited every time that I do. Again, because when we see what's going on at the front lines, it helps us not only connect hospitals with each other, because there's so much learning that we can do across the field, but also informs the work that we do on their behalf as an association in so many ways. I'm so grateful to them, so grateful to you, and to the folks who've been listening.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.